Okay, let's get started with chapter 36, chest trauma. This is part 1. So just a quick overview of thoracic trauma. Thoracic trauma, major contributor to serious injuries and fatalities in a lot of different settings. So according to the CDC, we see that more than 880,000 emergency department visits, they're due to thoracic injuries. And then those thoracic injuries account for over 35% of all trauma deaths. So a little bit of A and P. So let's talk about some anatomy as well as some structure of the thorax. So as you see on your slide, the thorax, it's just this bony cage that encases vital organs in the chest, and that provides protection and support. And then the thorax, it's kind of defined by these following structures. So posteriorly, the thoracic vertebrae and the ribs create the back boundary of the thorax. And then inferiorly, the diaphragm forms the lower boundary. That also plays a crucial role in respiration. And then anteriorly and laterally, the ribs outline the front and the sides of the thorax, and that contributes to its protective function. And then superiorly, we see the thoracic inlet that marks the upper boundary, and that connects the thorax to the neck. So still talking about the diaphragm and its attachment. So the thoracic cavity, it extends to the 12th rib at the back, and that diaphragm is attached to the lower 6 ribs of the anterior thoracic cage. So this attachment is crucial for its function in breathing. Now, as that diaphragm moves during breathing, it causes changes in the size and dimensions of the thoracic cavity, and that variation is important for effective ventilation, and then it needs to be considered also during your physical assessments of these patients with some thoracic trauma. So kind of just some characteristics of the thoracic region. So the thoracic region, it's well protected by this skeletal structure that we've been talking about, of the rib cage, the spine, all those things safeguard the vital organs within. It's also covered by some dense muscle tissue that provides additional support and movement as well. And then as you see on that slide, you have a lot of muscles that are listed. So these are all key muscles in the thoracic region. So we see the trapezius, we see the lats, the rhomboids, the pecs, the sternocleidomastoids. Those are all within this thoracic region, and that all have something to do with the purpose of the thoracic cavity. So we're still talking about the thoracic region. You notice we're going to talk about the primary physiologic functions. So the main goals in managing a patient, especially after trauma, that's to maintain one, which is oxygenation and ventilation. So we want to make sure that patient is adequately oxygenated and has effective ventilation. Obviously, that's crucial for survival. And then this helps to support those vital organs and then hopefully prevent complications as well. And then your second point, which is circulation. So maintaining proper circulation is going to be essential for delivering O2 and nutrients to the tissues while also removing those waste products. So, a stable circulatory system obviously is going to be key to this whole process. And then there's this impact of underlying medical conditions. So if a patient has underlying medical conditions, so even just some minor interruptions in those body normal processes, due to injury, that can severely impact an already compromised system. So if they already have, some respiratory issues and those type of things, that can really exacerbate these issues. So that's going to mean that we need to have more careful monitoring and management to prevent exacerbating these existing health issues from this thoracic trauma. Now, some pathophysiology. So traumatic injury to the chest obviously can cause compromise of ventilation, oxygenation, or circulation. And so these injuries that we're talking about, they tend to distribute those forces of impact over the surrounding area. So that blunt trauma, that can result in several serious injuries, which, with fractures, so we could see rib fractures, the sternum, chest wall, entire sections of the chest wall, bruising, so the lung and heart can sustain some bruising, aortic damage. So that blunt trauma can cause some significant damage to the aorta, which we should know is a critical blood vessel. And then lacerated organs, it can lacerate some intrathoracic organs, and that leads to some further complications. And then all the way up to displaced organs. So in those really severe cases, those organs can be torn from their attachments within the chest cavity. So blast injuries. We have a couple of types. So these injuries can present as either blunt or penetrating trauma, and that just depends upon the circumstances of the blast. So within that primary shock wave, we primarily see blunt trauma. So that phase involves a shock wave that compresses organs, and that's similar to the effects of blunt trauma. So the rapid pressure changes that happen, it can cause significant internal damage. And then the secondary phase, as you see, is penetrating trauma. So what we're talking about is, debris and objects that are thrown from the blast that can penetrate the skin and lead to penetrating injuries. So now these injuries, they all can vary in severity, and they all can affect various organs as well. So thoracic trauma, still talking about that. So in all age groups, thoracic trauma can obviously impair some cardiac output. So that can lead to reduced efficiency in how the heart pumps blood, and then a decreased blood pressure. So that reduction can affect perfusion to vital organs, and obviously that's going to compromise their functions. And then the bleeding that can happen into that thoracic cavity, that increases the likelihood of hypovolemia as well as hypoxia. We can see some increased interpleural pressure as well. So those pressures can decrease the lung volume. So, a result of that would be reduced oxygenation, and then impair the heart function as well. And that makes it much harder for the heart to pump effectively. We can also see some pericardial sac compression. So that blood accumulation in the pericardial sac can compress the heart, and that affects its ability to function. And then we can even see some injury to the heart valve, so myocardial valve damage. Damage to those heart valves can disrupt ventricular filling, which then leads to the backflow into atria and then inefficient blood circulation, as well as vascular disruption. So trauma can cause significant vascular issues, and we can see things like major vessels that are ruptured. That'll lead to fatal blood loss, or small tears or even blockages. So just minor injuries can result in tissue ischemia, where that blood flow is insufficient to meet those tissues' needs. Now, ventilatory impairments, these can be rapidly fatal and then significantly impact patient outcomes. So things that we're talking about is like some shallow breathing. Because this patient is experiencing some chest pain, they'll often breathe a little bit shallow to help with that pain. So what we see because of that is reduced minute volume. So that's the total amount of air exchange per minute, and then that obviously leads to inadequate ventilations. Also, we can see some air in the pleural space. So when that air enters the pleural space, it compresses the lungs, and then it decreases the tidal volume. So that means less air is exchanged with each breath. That again compromises oxygenation. And then of course there can be some blood accumulation as well. So blood collecting in that thoracic cavity. One of the downsides of that is that full lung expansion. So that restriction really limits the lung's ability to expand fully during inhalation. And then some various thoracic injuries can lead to fewer pressure changes as well. So that results in less movement of air, which ultimately decreases the amount of oxygen available for gas exchange. Remember that the whole thoracic cavity works off those pressure changes. So that's how that's affected. So some other complications, we see some atelectasis. So that kind of just refers to that collapse of the lung tissue. That reduces that area of gas exchange. So less surface area means less oxygen can be absorbed into the bloodstream. And then bruised lung tissue, that can lead to significant hypoxemia. So just this dangerously low level of oxygen in the blood, which obviously can have some serious consequences. Or then even tearing or rupture of respiratory structures. So injuries to the airways or lung tissue, it can prevent oxygen from reaching the alveoli, And then this disruption severely impacts the efficiency of gas exchange, and then that leads to inadequate oxygenation. Some patient assessment. A lot of this is just review, and we'll kind of highlight when we start talking about thoracic stuff. So obviously, safety first. Typically when people have these thoracic injuries, it's secondary to something bad happening. So, car crashes and assaults or a pressure wave blast and all these kinds of things. So safety first is obviously going to be a big thing. Standard precautions, PPE, all of those things are going to be big. So when we get into patient assessment, we want to identify the number of our patients. So maybe there was 3 people that were in the vehicle and they're all damaged. They all have issues. So, we need to triage some people, request additional resources, determine the mechanism of injury, all of those typical things. Now, common causes of these chest injuries that we're talking about can be motor vehicle crashes, some falls, especially falls from heights. That can result in serious chest injuries, and then assaults. So just some physical attacks that can cause blunt or even penetrating injuries to the chest as well. So we form our general impression, getting that overall sense of their condition. So kind of looking at the way I like to say it is, are they sick or not sick? And if you haven't heard this before, whenever I say sick or not sick, of course, a lot of people are sick that we run on in the ambulance. However, we're talking about, is there a chance that they're going to die before we get to the hospital? So that's what I mean by sick versus not sick. So, we want to form that general impression, and then we want to check their LOC, so their neurological status. Then, of course, we want to do a skin assessment. So we're looking for color, maybe look for any unusual pallor or redness or mottling. Moisture, so is the skin dry or is the skin clammy? That kind of can indicate some circulatory status changes. And then temperature, so warm or coolness, which can give us some clues about their condition. And then we move on to a full body assessment. So looking for obvious injuries, appearance of blood, difficulty breathing. So, are they struggling to breathe? Maybe they have some cyanosis, so, particularly around the lips or fingertips. Looking for any abnormal breathing patterns. And then, of course, with these being thoracic injuries, we want to look for unequal chest rise. An important piece to this, too, is some neck observations. So finally, we want to kind of assess the neck for accessory muscle use. So, we want to look for those signs of labor breathing where additional muscles are being engaged. And then we want to look for distended or engorged external jugular veins, so JVD. So this can indicate some increased pressure in the chest or even some heart issues. So we move on, we're at the airway and breathing. Now, considering they took a good shot to the chest, they may need some cervical spine protection. However, you'll follow your local protocols for spinal motion restriction and all of that. Next thing, we want to make sure that we expose the thoracic cavity. So really, to accurately assess airway and breathing, we need to carefully remove that patient's clothing to expose the thoracic cavity. That'll allow you to evaluate for any visible injuries. Also, just observe the mechanics of breathing. So we want to also, palpate the neck to check for some tracheal deviation. So that involves feeling the position of the trachea. So any displacement could indicate serious underlying issues such as a tension pneumo. And then we mentioned JVD before. So while we're examining the neck, we want to look for some JVD. As we mentioned, it can be because of just some built up pressure, that is going on within the thoracic cavity. So our thorax inspection. So, we want to begin our assessment of the thorax by checking a few of the following. So we want to make sure we check for the contour. We want to observe the shape of the chest, look for deformities or abnormal contours. That might indicate some injuries, as well as looking at the appearance. So we're looking at the skin over the chest for any signs of trauma, bruising, laceration, swelling, and then of course symmetry. So symmetry between the left side and the right side. We would expect equal chest rise, equal fall. However, whenever we see things like a tension pneumo or rib fractures or flail segments, we'll definitely notice some differences. So we're continuing on with airway and breathing. You see signs of underlying injury with the potential to compromise breathing. So some of those might be soft tissue injury, so we want to look for those signs of trauma to the skin or underlying tissue. And then paradoxical motion. So we want to watch for sections of the chest wall that move inward during inhalation and then outward during exhalation. That indicates a potential flailed chest. And then retractions as well. So, we want to notice that the skin is pulling in around the ribs during breathing. That can signal respiratory distress, as well as some subacute air or even edema. So we're feeling for air beneath the skin or swelling in the chest area. Impaled objects. So, we want to identify any objects that might be lodged in the chest. And then penetrating injury. So look for those wounds that penetrate the chest wall. And we know those can lead to some serious complications. And then we definitely want to make sure we're addressing these things. So, we want to prioritize, we're kind of addressing life threats, we're addressing life threats. So prioritize addressing those life threats that are associated with penetrating trauma or paradoxical movement of the chest wall. Those conditions require some immediate attention to stabilize that patient. So we want to get in, we're still talking about airway and breathing, so we want to assess the ventilation and oxygenation. So it's crucial to evaluate how well the patient is breathing and then getting oxygen. So the way we can look at that with a few little things is their respiratory rate. We can look at their depth of breathing, and then is it shallow or is it deep? And then how hard they're working, so their effort of breathing. And then if they appear to be struggling to breathe, that might indicate some serious respiratory distress. And then O2 administration. So probably all of these patients with severe thoracic trauma should probably get 15 liters per minute, depending, as I always say, depending upon your local protocols. And then if their breathing is inadequate, make sure that we administer some positive pressure ventilations with 100% O2. That helps to ensure that they receive that sufficient oxygenation. And we want to look for some effectiveness. So we want to monitor the effectiveness of what we've done. So remember, we talked about addressing life threats. We've put on some O2. We might be ventilating them. We want to evaluate the effectiveness of what our interventions are. And we want to check for that signs of improved skin circulation, normal color, warmth. We also want to monitor their SpO2 levels. And then we want to make sure we're paying attention for a tension pneumo. So we want to be alert for signs of that impending tension pneumothorax, so such as sudden respiratory distress, decreased breath sounds on one side, or hypotension. That condition can rapidly become life-threatening, and it requires urgent intervention as well. And then kind of our final steps of this breathing assessment. So we want to start thinking about point tenderness. So we want to press gently on the different areas of the chest. We're looking for any specific points that are painful to the touch, as well as some bony instability. So we want to feel for any irregularities or instability in the ribs or the sternum. That can certainly suggest some fractures. We want to look for crepitus. So we're thinking about either, there's a couple different ways, kinds of crepitus we can feel for. So one is to listen for or feel for a crackling sensation under your fingers. That can indicate some air escaping in that subacute tissue, as well as probably where my mind goes with crepitus is more of those bony ends that are kind of grinding on each other. And then we also want to check for subacute air, so subcutaneous emphysema. So what we're looking for is that air trap beneath the skin that creates a distinctive feeling and may indicate a serious injury. So kind of that snap, crackle, pop, the Rice Krispies thing. And then edema. So assess for swelling in the chest area, and that can signal some underlying injury or, of course, some fluid accumulation as well. And then percussion. So, after palpation, perform percussion on the chest. That'll help you identify any abnormalities. So some hyperresonance, that may indicate conditions like a pneumothorax where air is present in the pleural space. Typically when you do a percussion exam with that, you would expect if it's hyperresonant that it sounds more hollow, and that's because there's air trapped in there. And then you see the word dullness or hyperresonant. That dull sound can suggest that fluid accumulation, so maybe a pleural effusion or underlying issues, more like a hemothorax or something like that. And then auscultation. So finally, use auscultation to assess some lung sounds. We want to make sure we're paying attention to adventitious lung sounds. So listen for any abnormal sounds, such as wheezing, crackle, stridor. All of those can indicate some respiratory problems or obstructed airways as well. And then we want to ensure to check for lung sounds. So in all fields, listening for symmetry and clarity. So we want to do confirmation of lung sounds. And that helps confirm that both lungs are functioning properly. Then we get into circulatory assessment. So we want to assess the quality of the pulse. By doing that, we're looking at hemodynamic stability. So, that quality of the pulse can help you determine how stable the patient's circulation is. So a weaker thready pulse, it may suggest a compromised blood flow. And then we're also thinking about maybe some cardiac tamponade indicators. So we want to pay attention to those pulse characteristics so they can provide some clues about conditions like cardiac tamponade, where fluid accumulates around the heart. And by doing that, it affects its ability to pump effectively. And then if it's appropriate, which in what we've been talking about, it would be that we want to put on an ECG, an EKG monitor. So it won't delay the primary survey. If it won't, rather, consider using an ECG monitor. That can help provide valuable information about the heart's rhythm and overall function. However, don't make sure it doesn't interfere with your initial assessment and your interventions. So we're still talking about our circulatory assessment. So we mentioned JVD before. So when we're looking at the neck and thinking about circulatory assessment, so when you talk about JVDs, when you observe some JVD like you see in that picture, that can provide some insights into that patient's central venous pressure. So elevated JVD may indicate several underlying conditions. One of them could be a tension pneumo. So it has that increased pressure in the thoracic cavity. That can cause the JVD. Volume overload can as well. So excessive fluid in the body, that can lead to distended veins, as well as some right-sided heart failure. So the heart's, you get that backup. So the heart's inability to pump effectively, that can result in increased venous pressure. And then we've mentioned it, but that tamponade as well. So has that fluid that surrounds the heart, that can also elevate JVD. Now typically JVD is best assessed when that patient is in a 45-degree semi-Fowler position. So that may be challenging, however, with some of these patients, because if spinal precautions are in place, it's going to make it a little bit harder to do that. Now, if you don't observe JVD in the supine position, along with other physical findings, it may suggest a hypovolemic state. So that indicates that low blood volume that requires some immediate attention. And then we move on to auscultation. So we want to auscultate the heart. We want to listen to those heart sounds. It's going to be essential. And we want to look at, are those tones easily heard, or are they muffled? So clear heart sounds are a good sign, while muffled heart sounds can indicate serious conditions like a cardiac tamponade. So those situations may require urgent intervention. However, that's not when you hear intervention, that doesn't necessarily mean a procedure that we would do. It's recognition that these people are super sick and we need to get them moving. And then assess for shock. So even if your assessment suggests that the patient is in shock, remember it may not be necessarily due to thoracic injuries. So we probably want to obtain a history. So get a thorough medical history from the patient or bystanders, because there may be some other causes. And then, of course, complete a physical exam. By doing that, we're looking for other significant injuries that could be contributing to that shock state. So, they may have been in a bad crash and they have a femur fracture or a pelvic fracture and are losing a lot of blood internally, and that could certainly cause those shocky signs and symptoms. And then our transport decision. So, we're talking about getting the right people to the right place. So within this, we want to make sure that we prioritize those patients with our ABC problems, so airway, breathing, circulation problems. We want to focus on transporting them that are having, though not them, those patients that are having those issues. And then we will make sure we want to look for some subtle clues that might indicate a life-threatening injury. Skin appearance is one. LOC changes, so altered mental status, that can suggest inadequate oxygenation or blood flow. And then that sense of impending doom. So if they express a feeling of impending doom, my suggestion is to take it really seriously. It can be a significant indicator of distress. And then we talk about signs of poor perfusion or inadequate breathing. So if you observe those signs of poor perfusion or inadequate breathing, we want to prioritize rapid transport to a medical facility. Of course, conduct the rest of your assessment while en route. Make sure you gather all the necessary information, provide ongoing care, but don't mess around on scene, doing a big long assessment with someone that's critical. So chest injuries. So when in doubt regarding these chest injuries, make sure that you err on the side of caution and then transport that patient rapidly. Quick actions can be critical in these type of situations. So history taking, we see, can be done en route. You can use sample. So some of the questions you might want to ask: the speed of the vehicle or the height of the fall. Were they wearing safety equipment? So were they restrained or were they not restrained? If they were assaulted, type of weapon that was used, as well as the number of penetrating wounds. Those are going to be pretty important things as well. So then your en route assessment. If they have a significant MOI, a secondary assessment can be performed while transporting them to the hospital. So you do want to use this time effectively. So it might be effectively to gather more information. However, it might be more effective to continue on with your primary survey. Remember, many of these times, these secondary assessments, in my opinion, are to make sure we didn't miss something in our primary assessment, or that they're desatting, or something is just evolving to where now their airway is becoming an issue, or whatever, something's going downwards. So within that head to toe assessment, cervical spine, obviously. On the back, we want to look for any signs of trauma or deformity, abdomen, tenderness, rigidity, and then of course neurologic and circulatory function. And we want to look for injuries that are compromising those ABCs, because that's something we might have to deal with later. So some of those things can be like an aortic transection. That can be life-threatening. A greater vessel injury, so those serious injuries to major blood vessels, they can lead to rapid deterioration. And then even bronchial disruption, so damage to that bronchial tubes, that can affect breathing. Myocardial contusion, so bruising of the heart, may impact cardiac function. Not uncommon to see some weird rhythms, and obviously the heart's going to be pretty irritable at that time with a myocardial contusion. Pulmonary contusion, so some lung bruising, that can definitely lead to respiratory distress. Maybe a simple pneumo, so just air in the chest cavity, that can compromise lung function. And then rib and sternal fracture, so obviously that can cause pain, and that pain typically can then cause some respiratory issues as well. Get you a full set of vitals, so capnography, pulse ox, those are going to be really important in these type of assessments and these vital signs that we're talking about. Now, if that chest injury is isolated, and associated with a limited mechanism of injury, you probably want to concentrate your assessment on a few different things. So that isolated injury, you want to confirm that injury is indeed isolated. That's going to probably simplify your evaluation as well as your management. And then you want to listen to your patient's specific complaints regarding their chest. So, understanding their symptoms can help guide your assessment as well as some treatment decisions. And then pay attention to that specific area of the chest that's affected. So look for signs of trauma such as swelling or bruising, deformity, crepitus, those type of things. And then a quick head-to-toe assessment for significant trauma. So, in cases of significant trauma, it's crucial to perform a rapid head-to-toe assessment, and then a few things you want to kind of focus on. So make sure you're still looking at the skin, signs of trauma. So ecchymosis, that bruising, that can indicate internal bleeding or injury. And then identify any cuts or abrasions or signs of injury. So, just that other evidence of trauma. And then we want to make sure that we thoroughly examine the patient to locate any wounds and control any active bleeding. So we want to make sure that we identify all those wounds. And then documentation, so document where those injuries are located and assess their severity. That information is going to be critical for treatment. And then look at some underlying systems. So, evaluate the impact of injuries on those underlying systems, such as checking for signs of respiratory distress or circulatory instability. And then examine the front and the back, so anterior and posterior chest wall aspects. So ensure a careful examination of both the front and the back of the chest. Things we want to look for: some deformities, tenderness, respiratory movement, those types of signs and symptoms. So when we talk about significant trauma, that affects multi-system trauma is what we're talking about. You see, it affects multiple systems. So when it's suspected to affect those multiple systems, we need to make sure we perform a thorough assessment to evaluate thoracic injuries. So focus on a few of the following aspects. I always say few. What I mean by is just focus on the following aspects. So a full body scan. So conduct that comprehensive exam to determine the nature and the extent of those thoracic injuries. And then we want to inspect for deformities. Multiple rib fractures can lead to pain and respiratory complications. Of course, we could see some crush injuries. So significant force can cause severe damage and then warrant some immediate attention. The significant chest wall injury, so a deformity in the chest wall, that should be noted. Identify puncture or penetrating injuries. So take note of any puncture wounds. May indicate an open chest injury, which requires urgent care. And then assess also, of course, depending upon what your call was, but they may have some associated burns. So we want to recognize that those burns in the chest area can alter respiratory mechanics, and they may also complicate the patient's condition. And then palpate for tenderness. So gently palpate the thoracic region, identify areas of tenderness that may indicate underlying injury, and of course lacerations as well as local swelling. That's something that we want to make sure we're taking care of as well. And then reassessment. So not a lot here to talk about, as hopefully you figured out went through your physical assessment, your patient assessment chapters, but repeated assessment is going to be important with these guys. Vital signs, we want to make sure that we're regularly checking their vital signs or monitoring their oxygen levels. Make sure they're receiving adequate oxygen, which is going to be really important for oxygenation. And then we want to assess the patient's circulatory status, looking for signs of shock, compromised circulation, of course breath sounds, so auscultate the lungs, evaluate breath sounds. So as we see, talking about pneumothorax being suspected. So if a pneumothorax is suspected, we want to consider the patient to be unstable. It's crucial to reassess frequently. So we want to check that patient at least every 5 minutes. We're looking for things like worsened dyspnea. So increased difficulty can indicate worsening of the condition. We want to look for tachycardia. That elevated heart rate may signal stress or compromised circulation. And then that JVD development that we've mentioned before, that can be a sign of increased pressure in that thoracic cavity. And then be aware that other chest injuries, they might suggest more serious underlying condition, and that's going to necessitate careful evaluation as well as monitoring. And then throughout on-scene treatments and during your transport, keep a high degree of suspicion for any changes in the patient's condition. All right, medical care. So management of these type of patients is going to be, with potential chest injuries, we're going to kind of concentrate on the following areas. So we want to make sure that we maintain the airway. We want to make sure their airway is clear, secure. That helps to facilitate effective breathing. We want to make sure we ensure oxygenation and ventilation. So we want to monitor and provide adequate oxygenation and ventilation to support their respiratory needs. Support circulatory status. So assess and support their circulatory status to maintain blood flow, prevent shock, and then of course expeditious transport. So, arranging for a prompt transport, whether that's in the air or on the ground, there's a lot of this stuff that is going to be very crucial and very time sensitive with these patients. So airway management with these patients. Airway management for patients with these chest injuries follows standard trauma protocols. However, there are a few critical exceptions. So the jaw thrust maneuver, instead of that head tilt chin lift technique, use that jaw thrust maneuver to open the airway. This helps minimize movement of the C-spine. We want to avoid nasal airways. If there's signs of facial injury, don't use those nasal airways. Obviously, that can lead to further complications. Now, in certain cases, you may consider performing endotracheal intubation to secure the airway, but one thing to think about is there is a possibility of a tracheal injury, or if there is a possibility of that tracheal injury, then be cautious, because placing an endotracheal tube, that could certainly worsen a partial tear. So we're talking about a partial tracheal tear. That's why we would reconsider the endotracheal intubation. So you always aim to use the least invasive airway management techniques that's possible to minimize the risk. So really, we're just looking for kind of the least invasive approach with people that we might think have some other issues going on. So ensure oxygenation and ventilation. We're going to do that by putting on some O2, use a non-rebreather mask. We may need to ventilate them, make sure they're receiving sufficient oxygen. And then you may need to provide some ventilatory assistance. However, if you do, make sure you do it carefully and vigilantly. So with positive pressure, there is a caution here. So be aware that positive pressure ventilation can potentially expand a pneumothorax. It can convert it into a tension pneumo or increase an air dissection. So should not be withheld, but it must be delivered with care, and then monitor closely for visible chest rise while avoiding overinflation. And then assessing the circulatory system. So make sure that we're evaluating the circulatory system's ability to provide adequate oxygenation and ventilation. So if the circulatory status is compromised, then we need to implement some supportive measures to stabilize that patient. Now, pharmacologic agents, not a lot of things here that we're really going to talk about. Generally limited, but it does focus on a few key areas. So obviously airway management is one. So, the use of specific meds as needed to facilitate that safe and effective airway management. Of course, pain management, so some pain relief using both non-narcotic and non-narcotic analgesics. That'll help manage the patient's discomfort. And then just consider a range of options, but choose, according to your patient's needs when we're talking about the type of analgesics. And then pain management, it can be restricted by a couple of things. So, local protocols, depending on what your protocol is, that can dictate the meds that you have available. And then, of course, just that clinical state. So the patient's condition may influence which medication can be safely administered as well. So some non-pharmaceutical approaches. So you see splinting injury. So use those splints to stabilize the injured limb. Also helps to reduce pain. Cold pack application, to help minimize swelling, provide some relief, and then careful handling, of course. Make sure we're getting them to the right place. So, always aim for transport to a trauma center, because we're talking about some pretty sick people with good chest trauma. They're equipped to provide, obviously, specialized care for serious injuries. And then this should go all the way back to your EMT, and we've talked about it several times, but just kind of that golden period principle. So remember the principle of the golden period or the golden hour. That's critical time. That is a critical time frame during which the treatment for shock or traumatic injuries, it's most effective, and the chances of survival are the highest. So really, from the time the accident happens, whatever the injury happens rather, to the time you get into the ER, we really need to shoot for that being within that hour. Okay, there we go. That's to be continued slide. So that's the completion of part 1, and we'll talk to you guys for part 2.